Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Pembrolizumab for Patients with Refractory or Relapsed Thymic Epithelial Tumor, an open-label Phase 2 trial by Cho et al. My name is Jonathan Reese, and I am Assistant Professor at the UC Davis Comprehensive Cancer Center in Sacramento, California, USA. My oncologic specialty is thoracic malignancies. Thymoma and thymic carcinoma are rare malignancies, but they represent the third most common type of primary mediastinal tumor. Often, thymic tumor is admixed with lymphocytes and the development of T cells occurs in the thymus. There are two main subtypes of thymic epithelial neoplasms, thymoma and thymic carcinoma. Thymoma are further subdivided by WHO histologic classification A, AB, B1, B2, B3, based on the lymphocytic component. Thymic carcinomas histologically resemble other non-thymic carcinomas, with squamous being the most common histologic subtype. Neuroendocrine tumors in the thymus can also occur. Thymic carcinomas are generally more aggressive than thymoma. They tend to present in more advanced stages and are more likely to recur and have worsened survival compared to thymoma. Thymic malignancies, particularly thymoma, are associated with paraneoplastic syndromes. The most common is myasthenia gravis, but less commonly pure red cell aplasia, hypogammaglobulinemia, and other paraneoplastic disorders occur. PD-1 expression tends to be high in both thymoma and thymic carcinoma. Thymoma PD-1 expression ranges from 23 to 94%, and thymic carcinoma PD-1 expression ranges from 34 to 80%. There is some variation dependent upon antibody use for staining and institution where samples were tested. The lack of approved therapies in thymic tumors and the relationship between lymphocyte development and the thymus, as well as high PD-1 staining in thymic epithelial neoplasms, provides rationale for testing PD-1 and PD-L1 immune checkpoint inhibitors in this uncommon malignancy. In the manuscript by Cho and colleagues that accompanies this podcast, patients with thymic epithelial tumors who progressed after at least one platinum-based chemotherapy regimen were treated with pembrolizumab. Patients with active autoimmune disease requiring systemic treatment within the past year or documented history of clinically severe autoimmune diseases were excluded. Overall response rate was 24.2%, and the study met its pre-specified requisite number of responses. In 7 patients with thymoma, 2 had partial responses and 5 had stable disease. In 26 patients with thymic carcinoma, 6 achieved partial response and 13 had stable disease, resulting in an overall response rate of 23.1% and disease control rate of 73.1%. The median duration of response was 9.7 months, 95% confidence interval 2.4 to 17 months for thymic carcinoma patients, with the rest of the patients having stable disease. The median progression-free survival was 6.1 months for both thymoma and thymic carcinoma. The study met its primary endpoint of requisite number of responses for the Simon two-stage design, but substantial and severe immune-related adverse events were observed. 5 of 7 patients with thymoma, that's 71.4%, had grade 3 or 4 immune-related adverse events, such as myocarditis, hepatitis, colitis, thyroiditis, and nephritis. Due to the high incidence of severe immune-related adverse events, the study was modified to exclude patients with thymoma and any autoimmune disease regardless of severity. Interestingly, 4 of 8 patients with severe immune-related adverse events had a response to treatment. 14 patients had high PD-L1 expression of at least 50% tumor proportion score by the DACO-22C3 companion immunohistochemistry assay. 5 of these 14 patients whose tumor expressed high PD-L1 achieved a partial response, while none of the patients with low PD-L1 expression had a response. This study by Dr. Cho and colleagues was conducted in Korea. Other studies in thymic epithelial malignancies outside Asia also show clinical activity of PD-1 and PD-L1 antibodies with high rates of immune-related adverse events, many of them severe. Rajan and colleagues at the NIH presented a study of the PD-1 antibody avelumab at the World Conference on Lung Cancer in 2016. 7 thymoma patients and 1 thymic carcinoma patient were treated with avelumab. All 4 responders in the study experienced immune-related adverse events, including myositis, in 3 patients, all after 1 dose of avelumab. Enteritis was observed in 1 patient. In a single-arm phase 2 study of pembrolizumab and thymic carcinoma by Giacconi and colleagues at Georgetown Lombardi Cancer Center, 40 patients with advanced recurrent thymic carcinoma who progressed after at least 1 line of chemotherapy received pembrolizumab. Activity was comparable to this study, 22.5% overall response rate and 53% of patients achieved stable disease. 6 patients, 15%, developed severe immune-related adverse events, including 2 patients with myocarditis, 5%. Duration of response was 22.4 months, and median progression-free survival was 4.2 months. 6 of the 9 patients who responded to pembrolizumab had PD-L1 expression of at least 50%, and high PD-L1 expression was associated with longer progression-free survival and overall survival. Based on the current data available for thymic epithelial malignancies, how should we select patients with thymic cancer for PD-1, PD-L1 immune checkpoint inhibitors? In my opinion, I would not recommend treatment with PD-1 or PD-L1 immune checkpoint inhibitors in patients with thymoma. I agree with Dr. Cho and colleagues modifying their study to exclude patients with thymoma based on the immune-mediated toxicity they observed. I think the rate of immune-related toxicity is too great to warrant treating thymoma patients with PD-1 or PD-L1 immune checkpoint blockade, including severe immune-mediated side effects observed such as myasthenia gravis, myocarditis, and myositis. For thymic carcinoma, there is increased immune-mediated side effects, including uncommon side effects such as myocarditis that are higher than average for most other tumors, but less than thymoma. In these patients, I would consider pembrolizumab after progression on platinum-based chemotherapy, as well as other treatments. I would try additional chemotherapy and other additional therapies, such as sunitinib, which has a 26% overall response rate in thymic carcinoma. 6 of 23 thymic carcinoma patients treated with sunitinib on a phase 2 trial had a response before pembrolizumab, given the rate of immune-related adverse events. In thymic carcinoma, activity seems to be higher in thymic carcinomas with PD-L1 expression of at least 50% with a DECO-22C3 companion immunohistochemistry assay for pembrolizumab. In thymic carcinoma patients with PD-L1 expression of at least 50% and after progression on prior treatment, I would consider pembrolizumab after an extensive discussion with the patient of potential serious immune-related adverse events that could occur with the patient, including myocarditis and myositis. These patients should be observed very closely for development of immune-mediated toxicity. In summary, pembrolizumab and other PD-1, PD-L1 antibodies are risky business in patients with thymic epithelial neoplasms. I do not think these immune checkpoint inhibitors should be used in patients with thymoma. In thymic carcinoma, they can be considered in patients who have no history of autoimmune diseases, who have progressed on prior treatments, and who have high PD-L1 expression after extensive discussions of risks with the patient and close monitoring of toxicity. PD-1 and PD-L1 antibodies do have activity in these cancers, so treatments to prevent immune-related toxicity and new active immunotherapies that do not induce paraneoplastic syndromes and thymic epithelial tumors are greatly needed for patients with metastatic thymic epithelial neoplasms. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.